Hey everyone, my name is Stephanie Poland, and I am here to talk to you about the use of early progressive mobility in the neurotrauma patient. I am a registered nurse at a Level 1 trauma center, currently working in Southwest Virginia on a neurotrauma progressive care unit. I'm a unit preceptor. I've been on this unit technically employed for 10 years, but I did leave full-time to be a travel nurse and see how other hospitals operated and learned a lot in Houston. While I was gone, I did my RN to BSN online, and now I'm at University of Augustine for my doctorate in family practitioner. I love doing anything with my family. I love being in the mountains, and I love doing. So why early progressive mobility? Well, I am very passionate about neuro and trauma patients and neurotrauma patients. And one of the things that I realize is that these are very complex patients. Because of those complexities, they often get overlooked when it comes to mobility, which increases their hospital stay, as well as their several barriers or some staff and community members that lead to increased mobility. So I like to teach them mobility to the normalized systems they possibly can. So today we're going to go over the significance of the practice problem. We're going to talk about the contact patients with length of stay, the search strategy I use, the evidence that I found out there, what trends model I identified with the device, and implementing evidence-based practice for early mobility, and how I plan to get it, not just get it out to the units and throughout the system, but also how I plan to evaluate my data for determining also, there are some practice recommendations that I've discovered in my research and so the significance of my practice problem for early progressive mobility in any critical care patient, especially in the neuro, often find that they require team, staffing ratios from 1 to movement, patient dynamics, that we do have to consider too are making sure that our team is well prepared to be able to do this, that we have the correct provision in place so that we are not causing overcommitment, and that they are trained and appropriate to be able to have that medication that is able to continue to help them so that so my practice feedback question was, does early progressive mobility in a trauma patient lead to a decreased length of stay at 2 days compared to those who completed activities? For every trauma patient that comes to our doors, they get activity and stay. And what we're finding is that there's a limited search strategy on 3 different databases. It was rather complicated because early progressive mobility has not really been studied in the knowledge I had to use both of those in my searches. I had to do ambulation only, early ambulation outcomes. I used progressive mobility, but mostly just broken down as well as there are 10 articles that I was able to find on the web, and with those articles, only 2 of them actually had neurotrauma in the title. So it was very difficult to find information on this specific patient population, and I should have So the evidence for pain. Big thing that was seen is that it lowered the need for mechanical ventilation. Not necessarily the need for ventilation, but the need of ventilation. And that ended up increasing the incidence of pneumonia. Also, when early ambulation started in ICU, patients were able to ambulate independently earlier, self-care sooner, and increase the likelihood that they would be able to discharge with little to no assistance. It significantly lowered the incidence of deep vein thrombosis in the hospital and acquired pressure ulcers. Pressure ulcers alone affect 2.5 million patients a year, and it also represents 11.6 billion in extra healthcare costs, with an average adding on an average of $33,000 per hospital stay. So it's huge. For your deep vein thrombosis, they're going to affect about 500,000 people a year, and again, huge cost of healthcare, greater than $200 billion. And both of these hugely lowered prevalence in patients that would really not be able to. The other thing that it does is it improves patients' anxiety and depression and hopelessness. These patients are often here for long periods of time and start to wonder if they're ever going to get to leave the hospital because of their injuries, and the anxiety is caused by dressing changes, multiple blood draws, pain. And all three of these, the anxiety, depression, and hopelessness, can actually, as the patient becomes frustrated, lead them to become very hostile toward their caregivers. So as they were ambulated, they felt like they had more control. Pain is actually decreased, and aggression toward nursing actually was lowered. Early ambulation in the ICU is a huge predictor of the overall outcome for patients in the long term. It did decrease length of stay in the ICU, PCU, and overall hospital stay, which is what I was looking for in my particular question. I believe for ICU it decreased stays by an average of 2 days, and for overall hospital length of stay, 3.5 days. It is determined to be safe and feasible without a designated ambulation team, but you must have a committed team that says, we want to move these people, we know it's important, we can do this, and are supporting each other. So the change process I identified was advancing research and clinical practice through close collaboration, the ARC method, and the reason I liked it is it assesses the culture and readiness for system-wide implementation, identifies organizational strengths and barriers to evidence-based practice, identifies evidence-based practice mentors within the organization to mentor direct care staff on clinical units, implement evidence into practice, and evaluate outcomes. So it's a 5-step process which really goes well with what we need to do. And one of the key factors is, two of the key factors were what were our barriers. And so we looked at them and realized we don't necessarily need an ambulation team, but we do need committed people, which leads you to number 3, which is identifying who's going to sit behind this project, help be passionate about it, and help lead it, and make that culture change as we implement it into practice. And the biggest reason that I chose this was that this model falls so closely to the vision of Proven Clinic, which is where I am currently employed, and they are committed to evidence-based practice, but they want to do it in a way that their staff is supported so that any change is sustained long term. So for data-based evaluation, I chose the Mountain Nurse test, which evaluates the outcome of 2 different approaches, remembering I'm looking at the early ambulation implementation versus ambulate or activity as tolerated orders. I determined that my data was going to be quantitative, numerical, and interval. looking at number of days. And most of our collection is going to be done through the electronic medical record after the patient's discharge, because obviously we're looking at them this day. Our data analysis is going to be done through the paired t-test using the SPSS to evaluate our mean. I want to implement a bar chart because I think it's very helpful for people that aren't numbers people like myself to get a visual of this is just our practice change and this was our outcome, and it allows you to see in a picture form the not just the change but the difference that you made in these pictures. The other thing we are going to use is Microsoft Excel spreadsheet, and through that we're going to be able to look at we can compare neuro patients to trauma patients, complexity of injuries, gender, things like that. For dissemination, institutionally wise, I will present it to the Vice President and Chief of Nursing, as well as the directors for trauma critical care, President of Surgery, and the Director of Neurosurgery, because these are the groups that are going to work most closely with this change process, and they need to understand what we're doing, why we're doing it, and how they can be a huge part of the team in affecting this change. We're going to, again, identify leaders and mentors on the different units to help get behind this. Drive-by education for our staff, they like that. It's quick, it's not overwhelming, and they feel able to ask the one-on-one questions without being in a big group and the intimidation of, did I ask a crazy question? Implementing it into our daily practice, we have nursing shift huddle every shift, as well as interdisciplinary team rounds are done every morning. Those will help determine who is, or identify who's ready for early mobilization and who wouldn't be and why. For locally, I would also like to speak with the American Association of Critical Care Nurse chapter. Yes, it's been studied, but early ambulation in critical care still has kind of a faux pas to it. So we want to be very encouraging to get these patients moving. Nationally, I chose the Society for Critical Care Medicine because doctors and nurses are both involved in this particular association, and again, it's important that we're all understanding why we're doing what we're doing, and essentially the doctors are going to be, or physicians are going to be behind the orders supporting this protocol. The Society of Trauma Nurses is another good one, and they are working very hard to help lower the barriers or to make alterations for the barriers that many trauma patients have to being able to mobilize. And then the Critical Care Nurse Journal put out by AACN. It's a very easy to read, simple, at the bedside nursing, teaching, and is not overwhelming. So I think it's a great way to get the information out to people. So practice recommendations. Know your patient population. Know the barriers, know the risk factors, understand why you're moving them and why you wouldn't be able to move them. There's going to be a protocol so that you can look at it and know, does your patient meet the criteria? And that is for the safety of the patient and the safety of the staff. Education is going to be key to this change. Again, make sure your staff knows, and that goes along with being available, knows what you're doing, why you're doing it, and be there to help answer those questions, be there to help move those patients. And then utilize any opportunity as we're going throughout the facility to share the changes that you're making and why we're making those changes. The picture behind this says muscles, movement, and mobility. Every hour that our patients are down, they're losing muscle tone, so we need to move them so that they can mobilize. So in conclusion, early progressive mobility